Hello, everybody. My name is Dr. Al Heuer. I am a professor at Rutgers School of Health Professions. I'm co-editor of Egan's Fundamentals of Respiratory Care textbook, as well as two other textbooks. I'm also adjunct faculty in the respiratory care programs at Rush University in Chicago, at Rowan University in Southern New Jersey, and at County College of Morris in Northern New Jersey. However, I'm not coming to you in any of those capacities. I'm coming to you as co-owner of A&T Lectures. Terry Shenfield and I co-own A&T Lectures, but we also prepare and deliver a lot of the material, a lot of the lectures that you guys are enjoying and you're using to obtain continuing education units. This particular presentation is entitled Managing Pulmonary Infections, a Pathway to Patient Safety. Terry and I want to, number one, thank you guys for selecting A&T Lectures, and we really hope that you enjoy this presentation.
So the primary learning objectives we're going to focus on over the next hour or so, we're going to be describing the etiology, that's the root cause, the pathophysiology, so that's what happens at the tissue and cellular level, of pulmonary infectious diseases. We'll take a look at a few of pulmonary infectious diseases that affect children, in particular croup and epiglottitis. We'll also focus on several such diseases for adults. We'll review the clinical manifestations of such diseases. We'll discuss the treatment options of them, examine new discoveries related to COVID-19. I'd say more like newer, not necessarily brand new, but newer discoveries. And probably most importantly, I'll provide you with additional resources for those of you who wish to drill down and learn more about these topics. So to set the foundation, if you will, for this presentation, let's take a look backwards briefly at the history and the evolution of infectious disease. Now, I have a confession. Number one, I'm a germaphobe. Okay, anybody that knows me, I still work in a hospital, both at bedside as well as in clinical education of respiratory students. But I'm very careful. Wipe my stethoscope down. Before I go home, I wipe my shoes down. My shoes don't come in the house per se, et cetera, et cetera. I wipe my pen down. I'm just a little bit nuts. My cell phone several times during the shift, et cetera, et cetera. I'm also one of these people that's amazed that it's only been about a century or so that we've gained a decent understanding of how infectious disease, how these diseases spread, the different mechanisms, how we can actually help prevent the spread of these diseases, and how we can treat them when they occur. So going back before about 100 to 120 years ago, the prevailing belief was that disease was caused by bad air or night air. Okay, now that's not totally untrue. Okay, but back then they believed even walking through fog in a foggy street that was ill-advised. If there was a swampy area along a country road, it was ill-advised to basically go through the mist or the fog that was along the road there, because they thought that mist or fog universally contained, microbes. It was bad air. The theory was known as the miasma theory. Going back before that, Anton van Leeuwenhoek in the late 1600s, he discovered bacteria, but he, nor did his colleagues, know that it was pathogenic, that it caused disease. And indeed, it wasn't until 1928 that Alexander Fleming discovered penicillin. It was sort of by accident. It was indeed mold on bread, and they found that mold caused, inhibited, if you will, microbial, particularly bacterial growth. It wasn't until about another decade that they were able to advance enough with penicillin where it was commercialized and more readily available, which it was, by the way. By World War II, penicillin was pretty, I don't say universally available, but fairly widely available. And it was a game changer for certain, bacterial infectious diseases, respiratory and otherwise, that could otherwise be fatal, could successfully be treated with penicillin. Now let's take a look at some key terms when we're focusing on pulmonary infectious disease. We have a virus, one type of microbe, which is really kind of a simple, potentially deadly, but a fairly simple microbe. It's an RNA or DNA strand with a protein coat in a lipid envelope. It in and of itself cannot, if you will, multiply in and of itself. It needs a host. Bacteria, on the other hand, are cells which can independently multiply. There's a host of other microbes, including protozoa, rickettsia, amoebas, and many, many other forms of microbes. As I alluded to earlier, pathogenic has to do with the ability of the microbe to cause disease. Virulence has to do with the ability to cause severe disease. So, the earlier strains of COVID-19, for example, were particularly virulent. Thankfully, they were not that contagious early on, but if you got it, and in particular, if you got it and you had comorbidities and other risk factors, it could spell a very, very bad infection, potentially life-threatening infection. Transmission or the route of spreading, you can have direct spreading, somebody you touch a surface that's been infected, you touch a person who's infected, they breathe on you, they cough on you, etc. We also have the difference between sterilization and disinfection. Sterilization is the removal of all microbial life. Disinfection is not the removal of all, but it is the elimination of all vegetative. Okay, vegetative are basically living. Okay, they're viable versus a spore former. So disinfection does not generally eliminate spore formers. That would take sterilization for that. And spore formers, for instance, would be Clostridium difficile, Clostridium tetani, and other anthrax. Anthraxis bacillus is another spore former, and others as well. Thankfully, the majority, not all, but the majority of the microbes that can make us sick are not spore formers, So let's take a look at the diseases we're going to focus on mainly today. We could have cast a wider net, but we would never get through a presentation like this, going into this level of detail. If we casted a wider net, it would be a 2, 3, 4 hour presentation. So we absolutely were guilty of picking and choosing. In the pediatric population, we look at croup and epiglottitis. Part of that is because I'm still a respiratory educator, and clinically, we want our respiratory therapists to be able to identify the difference between croup and epiglottitis, but also on their credentialing exams, they really also expect the same thing. And you have croup that can, basically can be very serious. Rarely is it as potentially life-threatening as epiglottitis. So we'll take a look at those two individually and comparatively. Adult diseases, we'll look at tuberculosis, we'll look at both pneumonia, viral pneumonia and bacterial pneumonia. We'll take a brief look at SARS, and then we'll take not a deep dive, but we'll look at several facets of COVID-19, and then we'll kind of wind things up with some concluding comments. So the etiology of croup, it's a viral infection, influenza, respiratory syncytial virus, or RSV, and adenoviruses, because they're a family of viruses. Those are not the only types of viruses that can cause croup, but those are the most commonly implicated. So in comparison to epiglottitis, croup tends to have a more gradual onset, and it tends to affect a slightly younger group than epiglottitis, of 6 months to 3 years old. Regarding the pathophysiology of croup, it results in swelling and inflammation of the subglottic structures, the larynx, the trachea, and the larger bronchi. Can also affect mid-size and smaller airways. The clinical manifestations of croup include a slower onset, like a cold, that worsens, brassy barking cough, hoarseness, and audible stridor. We can argue that audible stridor is almost redundant because most forms of stridor you can hear with the naked ear. The neck x-ray can often show the steeple sign, which I will show you in the next slide or two. If severe, these next findings can really dictate whether or not the patient is admitted or not. So if they have tachycardia, tachypnea, if they have retractions, decrease in oxygen saturation, so hypoxemia, the ABG can also reinforce that hypoxemia and often will show respiratory acidosis. So if those particular findings tend to be, on the worst end of the scale and the patient really does not look good, then the patient will often end up being admitted for croup. So it's not that 100% of the patients that have croup are admitted, a relatively large percentage, but I would say in that mid-range, 40, 50%, maybe as much as 60% end up being admitted. Whereas with epiglottitis, they're almost universally admitted to the hospital. And as I alluded to earlier, the steeple sign, often found in croup. So the steeple sign is actually the patency. Okay, you see the trachea, you see that narrowing where that arrow is there. Again, it's not exactly a steeple sign, but it vaguely resembles one, and it's really showing you that those subglottic structures are swollen, and therefore the airway, the darker, the radiolucent or darker portion there, showing the trachea, there's a narrowing there that's depicting that swelling. So treatment, obviously prevention is the best. Good infection control techniques if someone else is sick in the family, or a family friend, a playmate of your child, young child is very, very, is sick and worsening. Good idea to kind of keep them away, keep your child away. And if there has been contact, try to use mask, hand washing. If there's toys that have been shared by among or between the children, the sick children, not sick children, is to make sure that they're disinfected and that the hands that touch them are, etc. But once this disease is contracted, the therapy includes a cool mist with oxygen via tent or face mask, reassuring the parental presence, racemic epinephrine via small volume nebulizer, or sometimes IPPB. And then there's a little bit of variation in the literature as far as if the patient is given racemic epinephrine, should they be given a half dose? So pretty much universally, epinephrine comes in a strength of 2.25%. But the question is, should the patient have the full dose, which is a half an ml that would obviously be diluted in 3 or 4 mLs of normal saline, or should they get the half dose of 0.25 mLs of that 2.25% solution? Systemic steroids, including dextromethasone, and gave you an example of a, if you will, a weighted dose, body weighted dose. Intubation is not common, not that it never happens, but if the child has a severe case of it, and it looks like they're starting to poop out, muscle fatigue, change in sensorium, cyanosis, bad ABG results, etc., severe retractions, then there's a chance that the patient could be intubated. Now let's alter our sights to epiglottitis. Unlike croup, which is viral, epiglottitis is almost always bacterial infection. Some of the more common implicated microorganisms include Staph aureus or aureus, group A and B, streptococci, strep pneumoniae, and other causes, thermal injury, caustic ingestion, radiation exposure, whether it's intended or incidental exposure through some sort of industrial accident, which would be the unintended, or if it's some sort of a treatment for cancer or head and neck cancer, it may have been an intentional exposure. The pathophysiology of epiglottitis, really focusing on supraglottic swelling. The epiglottis turns bright cherry red and swollen. Inflammation leads to airway narrowing and dysphagia. If severe, the airway can become completely obstructed. Obviously, that would be a very severe circumstance. Clinical manifestations building on the prior slide. Patient appears acutely ill, tends to be a rapid onset, Affects mainly children 1 to 5 years old. The child's throat, their airway is so swollen, painful. It's painful to even swallow their own saliva, so they can be drooling, sore throat, and dysphagia. Absolutely, stridor can occur, hoarseness with diminished breath sounds over the lung regions, high fever, and in this case, the lateral neck x-ray can show like a balloon-shaped epiglottis and can assume what's called the thumb sign. In the next slide, we'll take a look at really an image, an actual image of what that might look like. Lateral neck x-ray of the thumb sign. So whereas with the steeple sign with croup, the actual steeple sign was the opening, was the patency, okay? So it was radiolucent, it was dark. In the case of the thumb sign, it's radio opaque. It's the actual swollen, epiglottis and the supraglottic region. That's if you will, assuming that thumb sign configuration there. And you could see that the arrow is really kind of pointing to what it might actually look like on an actual neck x-ray of a patient who's experiencing epiglottitis. The treatment for epiglottitis includes, if you will, a montage of things. So minimal patient stimulation. So you still have a patent airway, otherwise the patient, would be coding. But the last thing you want is patient get too excited and have some sort of a laryngeal spasm and lose your airway altogether. So try to keep the patient as calm as you can. Many times, because they're a younger patient, you'll enlist the parents, the mother, the father, both of them, to try to keep the kid, if you will, quiet and calm. Cool mist aerosol with supplemental oxygen, antibiotics, and fluids are usually part of the mainstay as well. For some reason, they don't fully understand. Steroids tend not to be effective in this group, unlike the croup group. If severe obstruction, intubation should not be attempted by an inexperienced practitioner or in the ER. If it's absolutely necessary and it must be done in the ER, it's a good idea to also have a trach cut down kit there as well. But where possible, the patient should be intubated in the OR, as a trach may be necessary. The patient also may need a rapid sequence intubation with sedation and paralytics. The key is that if we have a strong index of suspicion that the patient has epiglottitis, and you work at a teaching hospital and the resident wants to get his or her last intubation in to get certified, this is not the patient to do it with. So just something to keep in mind there. Now let's shift our focus to adult infectious pulmonary diseases, including, again, we have a short list here, including tuberculosis, looking at both viral and bacterial pneumonia. We'll talk a little bit about gram staining, bacteria in the process, and then we'll take a look at COVID-19. This is not a presentation strictly on COVID-19, but we'd be remiss if we didn't, include it in view of the main theme of the presentation. Tuberculosis is in the the organism itself is the Mycobacterium family. So there's not one strain of tuberculosis, as probably, all of you know. And unfortunately, it does mutate, so that family gets larger and larger. There's more variety of specific types of microorganisms that account for the tuberculosis infection. Airborne transmission of droplet nuclei. Droplet nuclei are basically what happens with aerosol droplets when the moisture dries up. So it's analogous to a piece of dust, but it's large enough where that piece of dust, quote unquote, the microbes can take a ride on it. The unfortunate part about droplet nuclei is they can travel further than droplets. So whereas 3 to 6 feet is generally regarded as a relatively safe distance, droplet nuclei can travel further than that. The good news is the further you get away from the patient who has tuberculosis, the less, even if there's droplet nuclei, the less of a concentration you're going to get. And in fact, the propensity to develop the actual disease is somewhat dose dependent. So the more of it you get, the more the more of those microbes that you inhale, the greater chance that you're going to actually get the disease, versus if you just get a glancing blow with a few droplet nuclei in there, you may just actually get the difference between TB disease and TB infection, which I'll talk about very shortly. Droplet nuclei settle into the lungs and can start the infection. Risk of infection is determined by many factors. I just alluded to one of them, the concentration of the actual microbes that you've inhaled, the length of exposure, your immune status, and many other factors as well. Pathophysiology of tuberculosis. So the acid-fast bacilli, as they're known as, are inhaled and begin to multiply. Bacilli may migrate, not just stay within the lungs, but to the kidneys, the brains, the bones. 6 to 8 weeks after the infection, the immune response often localizes, contains the infection. Hence the difference between TB infection and TB disease. TB infection is the bacilli become inactive but remain viable. They remain viable. TB disease is where the active bacilli are not stopped by the immune system and continue to multiply. It's where people can get really, really sick with tuberculosis. The clinical manifestations include, but are not just limited to, a positive MAN2 test or PPD, purified protein derivative. The criterion for testing, if you will, have a positive MAN2 test does vary a bit based on immune status. So you get folks that are immunosuppressed, that have full-blown AIDS, that are on immunosuppressants for organ, to help inhibit organ rejection in the case of organ transplantation. There's other medications that patients are on for things like arthritis. The anti-inflammatory, if you will, steroidal anti-inflammatories that many times patients are on are the monoclonal antibodies to try to squelch the immune response in the case again of conditions like scleroderma, rheumatoid arthritis. Some of the skin conditions, etc., even multiple sclerosis. Those autoimmune diseases, in order to squelch them down, many times patients are put on a drug regimen which will reduce their immune response. That's the good news. The bad news is if they're more prone, if you will, to be vulnerable to diseases like tuberculosis, and hence their MAN2 test may not be 15 millimeters, the induration. It may be 5 or 10. So it's important. History and physical is very, very important in such patients. The chest x-ray, a lesion in the apical or posterior upper lobe. Basically, the acid-fast bacilli have an affinity for higher oxygen environment, and indeed there is a higher oxygen tension in the middle and upper portions of the lung. Positive sputum culture. Unfortunately, the acid-fast bacilli does not like to grow outside of the body. So many times the protocols for getting sputum are 3 consecutive days. Sometimes some of those protocols are 3 consecutive shifts. But irrespective, that want to get three good samples, and if the patient has one positive, it would be deemed that they will more likely have tuberculosis. Laboratory testing, increased bands, elevated alkaline phosphate, which is sort of a byproduct of the infection. Signs and symptoms: productive cough, chest pain, hemoptysis, weakness, weight loss, fever, chills, and night sweats. So that's that's not the entire list, but those are the kind of some of the major ones. So this is not an absolutely wonderful X-ray, but just to give you a basic idea, the actual cavitation. Okay, so what you see there, on that, looking at it, looking from us to the actual slide itself, the left-hand side. Again, if it's an AP X-ray, it was actually the patient's right side, but we're looking at it on the left-hand side there. You see what looks to be kind of a consolidation in the upper right lung of the patient, but the left of this particular slide. And then you see what looks to be a radiolucent, a black kind of a hole. That's suggesting it's a cavitation. And this patient is a known tuberculosis patient, and that hence notice it's also in the upper region of that right lung of the patient. The TB treatment. So I'm a Rutgers faculty, and in fact, the first effective antibiotic against tuberculosis was streptomycin, and it was indeed discovered by some Rutgers researchers. However, because over time the acid-fast bacilli developed a resistance to streptomycin, there's been many, many other drugs that have been developed and introduced. And many times when we're treating patients with tuberculosis, we're using multiple drugs. And interestingly enough or not, streptomycin is still used, but it's not a primary antibiotic against tuberculosis. It's used in combo. I would say it's more of it's a tertiary one that's, again, almost universally used in combination with other drugs. You have a 6-month regimen. I did not attempt to list all of the drug regimens here. The point I was trying to illustrate is there's different variants, a 6-month, a 9-month. There's also protocols out there for what's called MDR, multiple drug resistant strains for tuberculosis. And that's various combinations depending upon the actual strain or strains that are actually grown. So again, main theme, there's different regimens that are out there. However, before streptomycin was discovered and commercialized, the treatment for tuberculosis was supportive. It was many times these patients, if they could afford it, were sent to hospitals in the Rocky Mountains and in the Southwest United States, where the climate was, the air was clear, the relative humidity was low, the air was dry, and the patients got fed well. That if they could tolerate it, they had moderate exercise, they got plenty of rest, they were hydrated properly, and many of them improved. It wasn't that they no longer had the disease. It was their own immune system could now wage an appropriate battle against the acid-fast bacilli, and many of them clinically improved, and their life expectancy, though not necessarily normal, was improved as well. So let's take a look at pneumonia. Okay, and literally we're talking about pneumonia, we're talking about consolidation. We're talking about a portion of the lungs, the alveoli, that are flooded with mucus and or fluid. And we're not talking about transudate like you see with CHF. It would be more like congestion or mucus. It can be community acquired or hospital acquired, or what we used to call nosocomial. And there is a difference there, because if we think that the patient or the clinician has acquired a pneumonia from the hospital, many times the microbes will tend to be more resistant to some of the more common drugs, whereas community acquired, they tend to be more susceptible or sensitive to some of the antimicrobials. Again, the pathogens can be bacterial, viral, fungal, rickettsia, and others as well. So it's really kind of important. There's a microbe called coccidioides, and it can cause valley fever. We say valley fever. What valley? The San Joaquin Valley of California, but it's a disease that's more prevalent in the Southwest. I realize California isn't quite Southwest, but the San Joaquin Valley is, relatively contiguous to like Nevada. And you can have a fungus that can grow in the fields when those fields are plowed in the the late summer and early fall. Some of those spores can become airborne. If they're breathed in, the individuals can actually get sick with it. And the weird thing is, sometimes you get a patient who comes in, they're treated with antivirals or treated with antibiotics. They don't get better. One of my instructors when I was in respiratory school, Craig Scanlon, who was the former editor of Egan's Fundamentals of Respiratory Care. Craig actually traveled with his family, San Joaquin Valley, got valley fever, and was treated. He was sick. He was treated here. It wasn't getting better. Finally, a clinician, a doctor was asking, have you traveled? Have you changed your diet? Have you changed your occupation? Like, oh, didn't change my occupation. I didn't, but I did travel to California. Where in California? One thing led to the other. Treated him with antifungals. He got better in a week. So just FYI. So sometimes it's really kind of weird. You think viral or bacterial? Yep, most times viral or bacterial. But 3 to 5% of the time, something funky, something different than that. So now on to the pathophysiology of pneumonia. So often, again, the root of infection is inhalation of microbes or aspiration of stomach contents or other substances. The microbes include bacteria, virus. I kind of exhaustively talked about valley fever. And just another word about that. I went to a conference in Arizona, in Tempe, Arizona, and it wasn't a cab; it was a van driver from the airport to where we were staying. It was, when I mentioned I was a respiratory therapist, but it was actually an allied health convention. I mentioned I was a respiratory therapist, and he immediately said, "Gee, I could have used you a year ago." And he had valley fever previously. He said he was out of commission for like a month, month, 6 weeks, and he was only back to work like 3 months later, type of deal. So not common here. And when I say here, I realize people are listening from all over the country, but I'm from New Jersey, so in New Jersey it's not common. But you get people that we travel to that section of the country, or you get folks that you just encountered who've been there and they know somebody that has contracted it, whatever. But sometimes when they're not successfully responding to some of the other conventional therapies, then you got to start thinking outside the box, and there's something different about it. So on to the clinical findings of pneumonia. Indeed, patients can have walking pneumonia. So they may not feel good, okay, but they're able to function. They may not be breathing well, but they're able to function. But more cases than not, if a patient has full-blown pneumonia, they're ill. They feel like crap. Okay, they're probably not going to work. They have, hypoxemia, quite possibly, with some of the concomitant manifestations of cyanosis. Their chest X-ray can show a consolidation, so that radio opaque, the whiteness, if you will, an infiltrate or multiple infiltrates that the radiologists are famous for saying, atelectasis versus pneumonia. So we'll show a consolidation. It could be a unilateral pneumonia, so it could be unilateral chest expansion if it's a unilateral issue. Dull percussion notes, so we don't typically percuss. I will tell you, and even if there's nurses that are in the audience, that our credentialing body, the credentialing exam body, they expect respiratory therapists to know percussion. Now, they don't have to be perfect at doing the technique, but it would be a dull note. So when you percuss over air, over like a pneumothorax or air in the belly, it sounds hollow. It sounds what they call tympanic. When it sounds like it's fluid-filled or solid, okay, so it could be fluid, it could be mucus, it could be a tumor, it's more of a dull note. And it's one of those things that come with experience. I have indeed seen pulmonologists percuss, okay? It's not something that I do commonly, but it's something that they be aware of. And again, clinicians in particular, RTs, are expected to know how to do it and how to, vaguely interpret the results. Decreased breath sounds and or rhonchi, so you can have decreased breath sound over the actual consolidation, but maybe around the consolidation you have air movement, but it's moving through secretions, hence giving you that rhonchorous sound. Cough can be productive or non-productive. More commonly, it's productive. The productive part often will not start till, let's say, midway through the infection. So it's not like the first day or second day. That's where there's a lot of inflammation going on there. And then in the third, fourth, fifth day, there's the battle starts, between the body's immune system. So you can get not just the inflammation starts to subside, but you can get a lot of mucus, being released, and you can get a lot of cellular debris. So you have the microbes, but you also have the white blood cells that are fighting this battle, and the white blood cells die, the bacteria, the viruses die, so you get a lot of, if you will, sputum production, and the cough can become productive. Now, not so much now, but in decades gone by, the color of the sputum, okay, would be noted. We should note it as well. But for instance, foul-smelling green sputum was more commonly associated with Pseudomonas, okay? Yellow could be associated with, Staph aureus or aureus. Current red could be Klebsiella, okay? Now, I'm not making a definitive diagnosis based on red, green, whatever. Believe it or not, gray secretions can be associated with Legionella, okay? So again, you're not making a confirmative diagnosis, but you are having an index of suspicion. And you're certainly reporting to the physician that you believe that the secretions are purulent, okay? That they're thicker, they look infectious, maybe they're foul smelling, but they're foul looking, etc. And that's very significant. That may be a reason for a patient who has a pneumonia and is on a ventilator for not extubating them. Even though clinically they're improving, their blood gases are improving, if they still have a lot of, peri-infectious, purulent secretions, you want to probably hold off for a couple of days until those antimicrobials can really kick in nicely. So types, broadly speaking, types of bacterial pneumonia: gram-positive aerobic, gram-negative aerobic, anaerobic, and then the microbacteria that we were alluding to earlier on. So when you hear the laboratorians talk about gram stain will show, so you have, gram-positive rods, gram-negative rods, whatever. So you have the bacilli would be rods, okay? And in this particular image, when you see kind of, they don't look, they look long, they look elongated, okay? Whereas the cocci are more round, okay? And clusters and chains. The staining, if you will, when you talk about positive, it would be blue. So gram-positive bacilli are the longer ones that are blue, and then the gram-negative bacilli or cocci are going to be red. And this particular petri dish kind of shows you a smattering of, of both types. Treatment for pneumonia, certainly want to, get a culture and sensitivity to try to isolate the microbes, or if it could be multiple microbes. Supportive therapy, oxygen, rest, proper hydration, and nutrition can go a long way. As I alluded to, isolating the microbe through a sputum culture and sensitivity. So culturing it in the petri dish, and then introducing various antibiotics and antimicrobials to see what that zone of inhibition is, if at all. So it may not be sensitive at all to a particular, a bacteria. So the microbe may not react at all. It may be a small zone of inhibition. It may be an immediate large one, which suggests that the microbe is very sensitive to that antimicrobial. Antibiotics and antimicrobials, again, introducing them as well, particularly once you've isolated the invader, if you will, the invading microbe. Sometimes they're introduced just, not just, so we don't just start antibiotics, antimicrobials for no reason at all. But if we know that there is a particular type of, pneumonia that's going around, it would not be irresponsible if a patient is now manifesting the same symptoms, is to, once you get a culture and sensitivity, is start the patient on empirical antimicrobials, okay? It's a debatable practice, I'll tell you that right now, because you could be off the mark. But again, it's also something that the patient is declining very quickly and you really need to get ahead of the infection. It's something that, that should be considered. CPT, but it's not just CPT, it's really CPT, it's, hyperinflation therapy, it's things like even like metanabs to do your combination, PEP therapy, opening up the airways, but also mobilizing the secretions. Perhaps bronchodilators, perhaps mucolytics. Not a bad idea at all, because you think about the inflammatory cascade. So the patient has pneumonia, but they probably have an infectious pneumonia, so they have inflammation there as well, and they may not normally have, any bronchospasm, but they may be experiencing some of that now. So not a terrible idea to recommend bronchodilators, mucolytics, even inhaled steroids is not a terrible way to go, at least for an interim, until the patient starts improving. Now let's take a, not a detour, but let's just deviate a little bit over to COVID-19. And as I mentioned earlier on, this is not a presentation on COVID-19, but because COVID-19 has been such a big deal, has been so transformational in so many ways, starting a little, in early 2020 in this hemisphere, in this part of the country, but obviously starting at near the end of 2019 in Asia and elsewhere. So it's a viral infection. I don't think I need to really say that, but just for the sake of completeness, I will, or I have. Spread mostly via droplet infection. It may also spread via airborne. Indirect contact may also be possible, although we're pretty clear now that it's not a common way that this disease, that COVID-19 has been transmitted. The virus settles into the lungs and replicates, and it can absolutely migrate to other body systems as well. So after the patient is what we call infected or inoculated, I don't mean that they get a shot, but that they're infected. Um, Generally speaking, they postulate that as much as a 2 to 10 day incubation period, but they're thinking it's on the shorter end of that. 2 to 5 days, possibly as long as 10 days incubation period. The virus settles into the lungs, upper airways, and replicates, say, geometrically. So it goes 2, 4, 8, et cetera, et cetera. But they replicate very, very quickly. It's most contagious early on, and it is suspected that most contagious 1 to 2 days before the symptoms start and as the symptoms are starting and the patient's worsening. So it's, again, some of this is speculation, but there's not a ton of clinicians, nurses, RTs, and doctors that got COVID from while treating other patients. It's not that it didn't happen. It's not that it didn't happen, but it didn't happen nearly as much as they thought it was going to happen. Okay, early on, it seemed to happen more as it became less virulent and make you less sick. It also seemed like it became more contagious. But early on, there were not a lot of cases, if you will, transmitted from the patient to the clinician. And some of that they think is, well, the patient was most contagious before they felt ill and right after they started feeling ill. But then when they got really, really sick, you really had more of an, inflammatory issue going on there, and maybe the microbe was starting to migrate throughout the body, but, they weren't, it was less of an issue regarding the lungs. Again, it's a theory. Severity ranged from asymptomatic, as we saw with some of our younger patients, to multiple system failure, septic shock, and death. We'll talk a little bit more about mortality. And once you were put on a ventilator in this country, it was somewhere in the mortality rate was in the low 40s. It really depended on what hospital you were in, et cetera, et cetera. But it was, in that low 40s, 38 to 45% mortality rate. In some countries, patients were put on ventilators, but it was just the knowledge, the types of mechanical ventilators are very primitive. So some of those, and the availability of mechanical ventilation and supplemental oxygen was limited. So you had a much higher rate of mortality in other countries. And then you have, again, the immune system responds. The helper T cells identify the virus and they send white blood cells. Antibodies are also produced. And unfortunately, part of the process was a cytokine storm begins about on day 5 and peaks at about 10 to 12 or 14 days, and that's really flooding the airway and other parts of the body with inflammatory mediators. And those patients would often develop ARDS, but they could also develop things like renal failure, heart failure, clotting disorders, and the like. So it was, obviously it was a huge deal. I'm preaching to the choir on this, whether you're a respiratory therapist or a nurse, I'm preaching to the choir. But this was some of the kind of, if you will, the sequence of what was going on from a pathophysiological perspective. Building on the prior slide, the patient could be asymptomatic, but where symptoms occurred, mild to moderate loss of smell, fatigue, muscle aches. But then, approximately 1/6 of COVID-19 patients will have complications, including life-threatening ones. One of the real mysteries was, even if you just said, you took 50-year-olds, why it affected, even people in the same family, husband and wife, brother and sister, while it affected, the wife got sick for 5 days, but then recovered, and the husband ended up on a ventilator. Maybe he survived, maybe they didn't, but once you were intubated for respiratory failure secondary to COVID-19, your prognosis was just was not great. Fever, chills, hypoxemic respiratory failure, but could you also have an element of hypercarbia? Absolutely. Renal, hepatic, cardiac failure, so this is your multiple system involvement. The coagulopathies were of a major concern as well. Neurogenic conditions occurred both in the acute phases and in what they called long COVID. Septic shock, where a lot of these patients needed vasopressors. And I say in its worst form, I don't know if it's worst form, but, death. Could go on about it, but, A&T gives separate lectures on COVID, so we'll just when it comes to clinical findings, we'll stop during this presentation at this point and then move on to some of the other aspects of COVID-19. So chest x-ray depiction, again, it's a decent x-ray, but not, absolutely wonderful one, but it could be somebody with COVID-19. It could be someone with non-COVID-19 ARDS, but irrespective, this kind of, this ground glass appearance is what you often experience. And then if the patients developed that they were sick for a long period of time, some of them developed pulmonary fibrosis, in which case when you listened to them, it was almost like a Velcro sounding, I don't want to say it's classic, but thankfully a lot of the patients did not develop pulmonary fibrosis. But if they had, if they were event dependent and respiratory failure for COVID-19 for a long period of time, they did have a predilection to developing the pulmonary fibrosis, and some of them were potentially, when they stabilize, candidates for a lung transplant. And I'm not talking about a week after the infection. I'm talking about months after intensive pulmonary rehabilitation and optimizing the patient the best they could. Some of them ended up on transplant lists, and it's, I don't want to say worse form, but in a form that was closer to the worst than not. Regarding COVID-19 treatment, there was a whole bunch of things in our repertoire: supportive care, hydration, antipyretics that keep the temperature down and reduce the pain, bed rest. Except for remdesivir, antivirals were of limited use. Even remdesivir still recommended for use, but it was of limited value, not no value, by the way. Steroids to be timed, cytokine storm. There's a lot of stuff that's emanating now on the dosing of steroids, and it was really important to dose it at like a low to medium dose and not excessively, because when I say excess, not high dosing, because high dosing can also result in immunosuppression, among other things. And you certainly don't want to immunosuppress a patient who's has a COVID-19 infection. Started too early, thought to be potentially contribute to steroid-induced viral proliferation, because you again were squelching the immune response. Anticoagulation if the patient was manifesting coagulopathies. Dialysis, so you're supporting patients externally for kidney failure. Respiratory wise, supplemental O2 by a non-rebreather. High flow nasal cannula with flows not to exceed 30 to 35. We initially did not use high flow nasal cannula for a long period of time, much to my chagrin, and regarding the patients who were quite sick. Some of our sister hospitals in the same system did use high flow nasal cannula. A lot of the places were limiting flows to try to limit the extent to which the clinicians were exposed. So they would limit the flows on adult patients to 30, 35, something along those lines. Early versus later intubation, there's stuff written on that as well, almost like prophylactic intubation. Knowing a patient has COVID-19, knowing they're kind of, not circling the drain, but they're declining over a period of time. They really found that prophylactic intubation did not show, you don't want to wait till they're coding. But some of the patients, in fact, did not require intubation. They could weather the storm, 3 days, 2 to 3 days on a high flow nasal cannula. Generally, if you started to go beyond that, 3, 4, 5 days on a high flow nasal cannula, it tended not to be a good prognosticator in some that did need intubation. ARDSnet, so keep trying to aim to keep your plateau pressures equal to or less than 30, driving pressures less than 15. That was not always possible, but it was a goal. It was something that the clinical team were aiming for. If the plateau pressures were 35 or 36 or 37, trying to manipulate things like flows and tidal volumes and I times in order to at least try to get those plateau pressures as close to 30 as possible, with the goal of getting them equal to or less than 30. Likewise with your driving pressures. Low tidal volumes going at times not just as low as 6, but even as low as 4. Prone positioning in nitric oxide tended to have some sort of offer some sort of a benefit, particularly when the two of those were combined, because now you're proning patients, so the ultimate recruit maneuver, and now you can actually get the inhaled nitric oxide into the lungs where in fact you want to get it. A little bit on the prognosis and mortality. Again, if the patient did not require hospitalization, very low mortality. It's not like it was 0, but it was a low mortality rate. 0 to 5 for those, less than 50, but, over 8% for those that were greater than 70 years old. 12% of the cases required ICU admission. These are crude numbers. These are obviously kind of vacillating around 20 to 30% mortality if you went to the ICU. And then depending, it's a wide range here, 40 to 70% mortality if intubated and placed on mechanical ventilation. And again, if you were in a metropolitan area, Boston, New York, Philly, DC, Miami, Los Angeles, and I'm not leaving those out, but if you had good access to really, multiple hospitals that really can do a lot of good stuff, offer a lot of options with proning and inhaled nitric oxide, and, ARDSnet, you had knowledgeable intensivists, etc., that you probably were closer to that 40% mortality. If you didn't have access to those things, then you were higher up the scale. And they said in some countries it was like 80%. It's crazy stuff. Mortality by condition, so really by comorbid, a patient had, things like hypertension, they might have, 6%. If they had things like cardiovascular disease, then it increased it to, 10.5% mortality. So comorbidities matter is really, the main theme of this slide. So coming down the home stretch with regard to take-home messages. So there's no substitute for good infection control techniques. So, COVID-19 still with us. It was obviously much more severe 3 years ago, both mainly in severity. What you have now is probably a more contagious set of strains, but they don't make you as sick in general. Maintain an index of suspicion, just overall. So, not just talking about COVID-19, but respiratory syncytial virus. We had a bad outbreak this past winter, at least in the New York, Pennsylvania, New Jersey area, but there's other parts of the country that did as well. Just be careful. Be prudent. Identify and utilize practical resources. In the next slide, I'll be sharing with you some, resources that are out there and that are worth taking a look at. Participate in all appropriate training. Just as far as infection control, the different types of masks that we have, the PAPRs, etc. Good idea to stay current on that. Exercise common sense and good judgment. Just overall, last weekend or last Saturday, I covered the step-down unit amongst others, and there was just a lot of high flows going on out there. There was no positive COVID patients that I know of, that we knew of, but it was just enough respiratory interventions going on where I just wore an N95 when I was in that unit and going in and out of the rooms. Don't let your ego get in the way. It's not like, this microbe is not going to get me. I'll hold my breath. And, no, that's not nonsense. And, an element of humility. I'm talking to myself as much as any of you guys. If you have questions, ask. Or if you need additional information, ask. I learn things all the time. When I'm preparing these presentations, when I'm rewriting book chapters, I learn things. So I don't know everything, and just, I'm always open to learning. It probably makes me a better educator, the fact that I'm so open to learning. So just kind of be mindful of that. So with that, I want to share these selected references with you. First of which is really talking about hand hygiene. So indeed, there's, hand washing is still one of the best ways to help prevent the spread of infection. CDC's excellent source as well, not just on COVID-19, but just, on these microbes as well. And some of the other sources, Hopkins Medicine, two of my textbooks, Egan Fundamentals of Respiratory Care and the Clinical Assessment textbook, as well as some of your primary sources, PubMed and Medline as well. And with that, I want to conclude by thanking you all for joining us for this presentation. Hopefully you got, you really learned something, or I've reinforced some things you learned, and maybe they got pushed out from all the other stuff that got pushed into your brain. And I want to, just say thank you very much, and hopefully you come back to A&T lectures for your pulmonary respiratory educational needs. Thanks a lot, and have a wonderful day. Bye.